Yep, we can hear you.
Okay. Hello, and welcome everyone to this special session of the 2023 IHEA World Congress on the transformation of digital health in single-payer healthcare system of Taiwan. We will hear a lot about digital health in Taiwan, what they're doing, and what they're planning, and what their vision is for the future of healthcare in Taiwan. First, I'd like to introduce our keynote speaker for today. Our keynote speaker is Director General Chongliang Shi. In Chinese, it's pronounced as Chongliang Shi or Shi Chongliang. He was an immediate former Vice Minister of Taiwan's Ministry of Health and Welfare before becoming head of the National Health Insurance Administration earlier this year. Dr. Shi was trained as an MD and later got his PhD in health policy and management from the prestigious National Taiwan University. After working as an attending physician in the ER department at the National Taiwan University Hospital, that's the most prestigious hospital in Taiwan or academic medical center. It has Can you hear me?
Sorry, I was just muting everyone myself, but just a reminder to everyone to please stay muted. May, you're muted now.
Okay, now I'm back on, right?
Yep.
Okay. So I don't know where I got cut off just now. I was introducing our keynote speaker, Director General of Taiwan's National Health Insurance Administration. I was talking a little bit about his background, and he has a very distinguished public service career in the Ministry of Health and Welfare in Taiwan. He had been the head of the Bureau of Medical Affairs and the Bureau of Planning in the ministry. So thanks so much, Dr. Shi, for joining us today. We're very much looking forward to your talk. So next, let me introduce our panel for today in alphabetic order by name. First, Dr. Yasuke Kobayashi. He is currently a professor emeritus at the University of Tokyo. He was a professor of health policy and the founding dean of the School of Public Health at Tokyo U. He had been a Takemi Fellow at Harvard School of Public Health. And his research activities focus on topics related to health systems through developing empirical studies. He does evidence-based research, health services research. Our second speaker is John or Jack Langenbrunner. He is a health economist who spent 16 years at the World Bank as a senior economist working in Eastern Europe, Middle East, and Asia. Dr. Langenbrunner is now a retired consultant working for the World Bank, Gates Foundation, and USAID in Indonesia, India, Saudi Arabia, and Libya. I think with this palette of work, Jack is probably busier than when he was at the World Bank. And our third panelist is Morten Peterson. He is the CEO of the Danish National eHealth Portal since its founding in 2003. His expertise is in implementing e-health, e-services, and patient empowerment. Morten is passionate about health information technology as an instrument for improving healthcare system efficiency and yielding, I quote him, better treatments and happy citizens. So welcome to you all, and thanks so much for agreeing to be on the panel today. So I thought that before we go into the keynote, let me just say a few words about Taiwan single payer national health insurance. Some of you may not know very much about it, so let me just tell you quickly, give you a big picture of it. So can we have the next slide, please? Okay, so first is a profile of Taiwan. Taiwan has a population of roughly close to 24 million, but it's an aging society and it's a rapidly aging. You can see that from 2018 to 2022, the people over 65 went from 14.6 to 17.5. So that's rapid. That's really rapid. But the fertility is low, 1.1, but I don't know whether what it is this year may even be lower. I've seen a lowest of 0.9. But Taiwan is a very, very rich economy. Look at the per capita PPP for this year. This is an IMF number, $73,000. And life expectancy is about the same as the average for OECD, 80.4. Next slide, please. So now let's quickly look at NHI. It's a government-run social health insurance. It's run by the National Health Insurance Administration, or NHIA. And there's a mandate, everyone must enroll, but the spending, the national health spending is quite low, 6.6%. And this is very low compared to, I think, the 9.7 or so for OECD. And it's got full population coverage. And the financing is primarily through premium. And people are very good about paying their premiums. 99% premiums are collected on time. And government gives subsidies to people who have trouble paying premiums. So the premium payment is based on ability to pay. And the way Taiwan pays providers is with fee-for-service and DRG under a global budget. And there's a national uniform benefit package. So everyone gets the same care. So that's equitable. And the covered benefits are very broad: inpatient, outpatient, drugs, dental care, Chinese medicine, prenatal care, etc. And the wonderful thing that people love most, people in Taiwan love the most, is that they have full consumer choice. They can go to any hospital, any doctor, anytime. There's no gatekeeper like the UK NHS. And the majority, over 90% of the providers and 100% of hospitals contract with the government to deliver services. And the utilization, people love to use the NHI. Look at the number of visits. This is, for Western medicine, 12 visits per person per year. And in the OECD, number of visits per person per year is less than half of Taiwan's. Next, please. And so what the patients do pay co-payments, but they're very moderate, and there are ceilings and exemptions. And then really worth taking notice of is that the powerful IT system that drives Taiwan's NHI. Patients access care with a card, like a credit card. It's called NIH IC card. It's very convenient. And you just go in and swipe your card and you're into the system. And this also enables the government to collect near real-time NHI expenditure and utilization, and they can track diseases. Say they know very quickly, immediately, same day, if a pandemic might be happening or any other kind of public health if emergency. And then NHI is cheap to run, less than 1% of the total NHIA budget goes to administration. Next, please. Waiting times, I won't go explain it. It's pretty obvious. Just look at the slide that waiting times in general is not a very big problem at all in Taiwan. Cataract surgery, it's 11 days compared to, say, in some of the other single payer countries. In Canada, 49 days. UK, it's anywhere from 59 days to 62 days, whether depending on if you're in England or Scotland. So the same goes for knee replacement and total hip replacement. Next, please. And what about public satisfaction? The people in Taiwan, you hear so often, they say they love it. The sky can fall, but not NHI. I ask people, I talk to people everywhere, and that's what they say. And throughout the COVID-19 crisis, public satisfaction remained in the 90% range, and it reached an all-time high of over 92% in 2022. Next. Yeah, I just wanted to show you a couple of slides. This is from a book chapter that I did that shows you, what happens to a whole society, to a whole economy when the government does the right things and the people cooperate with the government. Here we look at the number of COVID cases and deaths per 100,000 people in Taiwan and on the left, and in Taiwan and in OECD countries. You can see for both number of cases and number of deaths per 100,000 people, Taiwan is at the very bottom there, very, very low end of the spread. And depending on what period you're looking at, sometimes it is at the very bottom, the lowest. Okay, next, please. And this is what happened to the world economy in 2020 when the world was in panic. And you can see that all the global GDP declined, the purple line minus 3.4%, Eurozone 3.7%, and the bars represent single countries, the red ones. Look at for the United Kingdom, the GDP dropped by 11%. But in contrast, Taiwan's economy grew by 3.26%. And people tell me that, life is good. That one even told me, a former head of the NHIA told me, we live in paradise. Next, please. But I just want to mention some challenges. NHI, as good as it is, does have challenges, and these are the ones that I, as a policy analyst, am most concerned about. I wonder whether NHI, there's an underfunding question. The low percent of the national health expenditure compared to every other country in the OECD, it's beginning to cause problems like long waiting times for and overly strict eligibility criteria for expensive treatments, such as immuno or targeted therapy for cancer and other serious diseases or drugs for rare diseases. And so this is something that I think Taiwan should have a national discussion and debate on, and do it sooner rather than later. I also am concerned about the high utilization, but the low willingness to pay, because past records showed this. And people love their NHI, but anytime you talk about raising the premium, they say no. So I wonder whether longer term, this will not lead to a phenomenon called the tragedy of the common. where NHI may be depleted, and so everybody would be worse off. And also, I worry whether there's a workforce shortage. You can see the doctor and nurse population ratios in Taiwan is far lower than what they are in OECD. Next, please. I think this is all I'm going to do. So let us now turn to Director General Shi and listen to him.
Good morning, good afternoon, and good evening, everyone. I'm Chongliang Shi, the Director General of the Taiwan National Health Insurance Administration. First of all, I want to extend our sincere gratitude to May for you hosting today's forums and the wonderful introduction about the Taiwan National Health Insurance. Without your great efforts, it's not possible to gather so many experts to exchange the point of view as well as the shared experience on the issue, a very important issue. Besides, it's my great honor meet Professor Kobayashi, Dr. Brunner, and Mr. Peterson in these special sections. As you know, the Taiwan National Health Insurance Program has been implemented for over 28 years, since 1995. It has been considered as one of the Taiwan's most popular public programs, and also something that Taiwan is proud of. Like many other countries with universal health coverage, Taiwan also faced the challenges um, such as the ensuring quality of the health care, maintaining the soundness of the finance, and the equitable healthcare resources distribution, as well as the building a resilient healthcare delivery system. The digital health transformation is what we have been promoting recent years. I will be very happy to share our experience with you in today's special section. Today, I will talk about accelerating digital health, the digital transformation of Taiwan's single-payer national health insurance. Next. My presentation will cover the three parts. First part, I want to explain the health service transformation during the pandemic, digital transformation of the national health insurance in the following section. Next. During the COVID-19 pandemic, telemedicine has emerged as the crucial service model in many countries around the world. Taiwan have introduced the telemedicine to cope with the challenges of the COVID-19 pandemic. Like the WHO's 2022 review on patient safety during the COVID-19 pandemic highlights the transformatic changes and the impacts from the following 8 perspectives. In order to cope with the emerging challenges, many healthcare organizations and providers makes a shift in service delivery models, including redesigned work methods, virtual care, as well as online education and training. Furthermore, as the healthcare through the telemedicine, utilization of the population's satisfaction is increasing. Next. The COVID-19 pandemic has significantly accelerated the growth for telemedicine service utilization. Using data from the US CDC as an example, telehealth visits in the first quarter of the 2020 increased by 15% compared to the same period in 2019. The global telemedicine industry, the annual growth rate also increased from 15% to 19% in 2020. And the market value of the global healthcare services sector reached $34.2 billion in 2022, experiencing a 22% growth. According to the World Bank's Digital Development Report in July 2020, the projected annual growth rate for the global telemedicine market is estimated to be between the 15 and the 19%, with the market value reaching the $175.5 billion. Next. So in this slide, let us review the major milestone of telemedicine development in Taiwan. Our Physician Act states that the medical services should only be performed by face-to-face, except of the special circumstance. Originally, telemedicine is allowed to apply in mountainous areas and outlying islands only. Then in 2018, the telemedicine consultation and treatment guidelines are expanded to 5 specific situations, such as the home care and the patients in the residential long-term care facilities. During the COVID-19 pandemic, telemedicine was further expanded to include home isolation, home quarantine, and the general outpatient care. However, the telemedicine will be limited to certain areas and the specific cases as the pandemic ends. So the regulations will be continuously updated to meet the future remote healthcare needs. In 2020, Taiwan's NHI started reimbursing the telemedicine services, integrating them with the IDS Integrated Delivery System program to improve access to healthcare in remote areas. Teleconsultations are conducted via video between local clinics and the telemedicine facilities, offering specialized consultations and emergency services. By the end of the 2022, 70% of the mountainous and outlying areas had joined the telemedicine reimbursement program. The use of the technology and IoT integration enables intelligent applications and facilitates the specialized consultations in remote areas. They offer specialized consultation and emergency services in ophthalmology, otolaryngology, dermatology, cardiology, neurology, gastroenterology, and respiratory medicine, and etc. In terms of the specialized consultation, dermatology and ophthalmology are the most commonly sought after, accounting for about 40 to 50% of the services provided. Otolaryngology has a lower utilization rate, comprising about 7 to 9% of the specialized consultation. During the COVID-19 pandemic, Taiwan's national health insurance reimbursed the telemedicine services for COVID confirmed cases and chronic disease patients as well. Patients could connect with the physicians at a scheduled time via video consultations. With the patient consent, physicians access the NHI medical information cloud system to conduct examinations, prescribe the medications, and update medical records. There were 3 ways for patients to obtain the prescribed medication after consultation. The first one, family members or agents could pay, swipe their NHI card, and correct the medication at the contracted medical institution where the consultation took place. The second one, the pharmacist also could deliver the medication to the patient's resident directory and charge accordingly. The third one, the patient with chronic conditions could receive a continuous prescription, which could be picked up by family. From May 2021 to February 2023, over 13,000 telemedicine institutions provided services, accumulating the over 13 million consultations. Notably, that there was a significant increase in service utilization during the peak of the pandemic. This highlights the significant contributions of the telemedicine in maintaining a stable healthcare services capacity and the facilitating the access to necessary medical services during the difficult time of the pandemic outbreak. Based on above the successful experience, we are going to revise the telemedicine regulations and the guidelines. The future direction will include the intent to broaden the applicable conditions for telemedicine. One, to relax the prescription restrictions for certain cases. We also plan to strengthening information security standards for telecommunication platforms, as well as to add new medical services for electronic prescription. Additionally, telemedicine will extend beyond the physical to a physician to physician consultation to including other healthcare professionals and the patients directly. In response to the needs arising from the pandemic, even the post-pandemic, the development of the non-contact medical services model is gradually taking place, constructing an intelligent healthcare system to meet the post-pandemic era becomes an important issue. We expect to promote the adoption of the virtual health insurance cards, to initiate the development of the subsequent digital healthcare services, including electronic prescriptions and online payments. This is to make the future healthcare model more flexible, resilient, and capable of meeting diverse healthcare services demands. During remote specialist consultation, patient can use a virtual health insurance card instead of the physical one. With the patient's consent, the remote teleconsultation platform can access their health information on the cloud-based platform using the health insurance EasyGo app. This app allows the healthcare professions to retrieve the necessary medical data, including the consultations, medications list, tests, and the imaging result. To address the issue of the handling the prescription slips in remote medical care, there is currently a discussion underway to establish a nationwide electronic prescription platform. This platform, combined with the medical identification code, will ensure the safety of electronic prescription and enable their seamless circulations among the healthcare institution, patients, and the clinics, pharmacies. To address the inconvenience of the electronic payments in remote healthcare, patients can also use mobile payment options such as the e-doctor pay, 接口 pay, or apay, the produce in Taiwan. Yeah, through the mobile apps to make the payment transactions. So this slide to show our public satisfaction. Taiwan's national health is one of the most highly regarded government services in Taiwan. Overall satisfaction among the populations is consistently above 70%. The main reason for decreased satisfaction, you can see the 3-point dropping, is consistently during the periods with the adjustment in insurance premium and our pocket expenses, such as the dual adjustment in 2002 and in 2006 and 2013. However, the overall satisfaction trend has been increasing over years. The NHI demonstrated resilience during the COVID-19 pandemic, contribution to the record high satisfaction rate of the 92.3% in 2022, despite a slight increase in the general premium rate from 4.69% to 5.17% in 2021. It did not significantly affect the public satisfaction. So the next slide. We have the so high public satisfaction. However, we still face the challenges such as the high healthcare utilization and the relatively low the input resources. Also, the increasing healthcare expenditure due to the new technology and the expensive drug today have the shortage of the maybe the healthcare workforce of the new drug, the introduction. The most important is the aging population and associated healthcare depends pose the most critical. So reform and planning are necessary to strengthen the national health insurance. So next. So there is a transformation in the health care delivery model, shifting from the provider center approach to an integrated care model centered around the patient. The focus is transitioning from disease treatment to disease management, even to ultimately to health management. The payment system is also moving from fee for services to case-based or value-based payment models. The digital tools such as the electronic health records, cloud data, telehealth, and the digital healthcare are being utilized to facilitate the success in healthcare transformation. So it's the most important infrastructure. So the My Health Bank launched in 2014 had approximately 1.6 million users before the outbreak of the COVID-19 pandemic. During the pandemic, This app, My Health Bank, played a crucial role in supporting digital technology for pandemic controlling, and prevention. It assisted in various tasks, such, such as the distribution, management of epidemic prevention supplies, PPE, and the medical resources, including the real name restriction for purchasing face masks, self-registration for vaccine administration, virus testing, and the real name registration for purchasing the rapid test kits. As a result, there was a significant increase in number of the user. By 2020, the number of the user has reached 11 million people, accounting for nearly 50% of the population. The usage count of My Health Bank has been accounted for about 332 million times. So this slide explains to you the major function of My Health Bank system. It integrates various health information, including the medical records from Western medicine, traditional Chinese medicine, dental care, hospitalization, medication, laboratory test results, health checkups, vaccination records, and other related health data from different departments. The systems also allow the individuals to upload their own physiological measures to assist them in strengthening their personal health management. So our next step is to develop the primary care platform. The data coverage of the platform will include the more is broadened, such as the National Health Insurance Administration and the related agency data, just I mentioned briefly, cloud-based data, query system data, and participation in various healthcare and the insurance program, as well as the records of the test results and the medical images. We also want to include the personal health data records from the CDC, such as the vaccination records, preventive health screen records, and etc. We also want to include the data from the personal wearable device or collaborated with private entities, as well as the data self-registered by individuals. So with the informed consent and the authorization of the patient, the primary care platform integrates the various data resources and applies them to risk prediction, abnormality management, analysis of the lab values, and the daily tracking of the patient's health conditions. So this is the whole picture of our primary care platform. This platform integrates the personalized digital records to effectively achieve the goal of patient-centered care service integration, information integration, as well as the financial integration. The information integration, just I mentioned in the last slide, enable the target analysis of the specific patient group, such as those with the diabetes, CKD, metabolic syndrome, and the cancer. It allows individuals to consent to receiving the care services and transfer their information to their personal health record for reference. We also want to achieve the financial integration through this platform. The digital data on the primary care platform serves as the reference for adjusting the payment system and determining the reimbursement content, such as the medical reports and the health improvement progress. This one of the most important function of this platform is to provide the service integration. This platform facilitates the integration of the various healthcare professionals, enabling collaboration and specialized roles among the different healthcare providers, such as the hospitals, clinics, pharmacies, long-term care facilities, and the home care services. It further develops indicators to enhance the quality of care, achieving the comprehensive case management, as well as reducing the health inequality. So furthermore, this platform also offers the customized AI management, allowing the healthcare providers to digitally track and manage the patients. It provides the reminders for routine screening and abnormal test results, enabling healthcare professionals to perform the patient tracking, remote monitoring, and telehealth education during the case progress. The payment is the one of the most the issue we concerned. So in the payment system adjustment aspects of the primary care program, adjustments are planned in 4 dimensions based on risk classification and outcome-based payment. The first one is we want to adopt the risk-based adjustment. Different level of the case management fees or weighted incentive are provided based on the severity of the different disease. This program also covers the cost of the case management and the tracking services provided by healthcare service providers for patient-centered care. The quality is we also concern. So this program will include the performance incentive, the fees, and the quality incentive funds. Additional services such as the integrated outpatient services for multiple chronic disease and the dementia consultation are also included. So last, but not the least, I will give you a summary and the future prospects. The goal of the digital transformation of the Taiwan's national health insurance is to enhance the efficiency and the security of the national health insurance information through 4 main strategies. One is to empowering people with health knowledge. Second is to optimize the efficiency of the national health insurance medical. Third one is to break down barriers in healthcare. The last one is to develop a data ecosystem. The aim is to provide the appropriate, accessible, and sustainable whole person healthcare for the people of Taiwan, as well as to achieve the Sustainable Development Goals 3 of the WHO, good health and well-being. This is my last slide. Next. The tower is the tallest buildings in Taipei. I hope all of you may have the chance to visit Taiwan in the near future. And now I thank you for your attentions and listening. And I very pleased to and welcome your comments and questions. Thank you so much.
Thank you very, very much for such a rich and informative talk. So I think let us move to the panelists and hear what they have to say. I think first, Yasuki, you're going to tell me about what Japan is doing.
Okay, thank you very much, Dr. C. Your presentation is great, and I think the direction of your system is similar to our system, but our system is not single-payer system, so the situation of Japan is somewhat behind Taiwan. The single-payer system is your very advantage. Okay, it's my turn. I would like to express my thanks to Professor May, Mei Cheng, and IHEA headquarters for inviting me to this Taiwan session. My talk is about the progress of the digitization of health record in Japan as of July 2023. Next, please. Next, please. Okay. My talk consists of 5 parts as shown in this slide. Next slide, please. Before the pandemic of COVID-19, progress in the digitization in healthcare had been slow in Japan. With regard to health insurance claims data, the necessity of digitization was suggested since the 1990s, but it was stagnant due to lack of support from stakeholders. Finally, in 2005, under the strong leadership of Prime Minister Junichiro Koizumi, at that time, the digitization and online billing of claims rapidly advanced. Okay. The subsequent progress will be mentioned later. The next slide, please. Again, the necessity of digitization was suggested since the 1990s. The paper here was mine, and with a colleague, I suggested the necessity of digitization for efficiency of health insurance systems. However, digitization of claims data was stagnant because medical record was not digitized, and therefore manual input work was required in claims processing. Second, many vendors for claims processing were already in business. It was very difficult to standardize code tables for claims processing. Third, digitization could make it easy to find outliers or questionable claims, and therefore medical associations, many physicians were reluctant for digitization. Also, the owners of clinics or small hospitals thought the investment in digitization was not worth the expenses. The next slide, please. But finally, in 2005, under the strong leadership of Prime Minister, the digitization and online billing of claims rapidly advanced. In 2011, more than 19% of medical institutions, excluding dental clinics, were digitized. Around 2015, it reached almost 100%, including dental clinics. The next slide, please. This is an image of the transformation from paper claims to electronic claims. Importantly, at the same time, uniform code tables were also created for diagnosis, procedures, pharmaceuticals, and so on. The next slide, please. The Ministry of Health, Labor and Welfare has constructed a database that includes claims data and annual health checkup data, and has begun to provide anonymized form of the data for research. The anonymized form of the database is named NDB Japan. This figure was made by Initiative for Clinical Epidemiological Research, a research consulting firm in Tokyo. This figure shows the number of research papers using NDB Japan is steadily increasing. Besides NDB Japan, several databases using anonymized form of claims and health checkups data has been also developed and widely used, not only for research, but also for marketing of private firms. If it is possible to link such data with individual patient will be able to check the contents of their own claims, such as procedures, prescribed drugs, and the amount of expenses, as well as past health checkup data. But the linkage has not yet been realized. The reason will be explained later. The next, please. After the pandemic of COVID-19, both the public and private sectors keenly felt the need for digitization in healthcare. As an immediate task, an infectious disease reporting system was taken up, and HERSIS was developed. Regulation related to online medical consultations were also reviewed, and payment for online consultation were generally expanded. The next challenge is to link claims data with individual patients so that the individual patients are able to check the content of their own claims, such as procedures and prescribed drugs, as well as past health checkup data. The next, please. This is the HERSIS systems. HERSIS Health Center Real-Time Information Sharing System on COVID-19 was a government-initiated digitization of patient reporting and follow-up systems. With HERSIS system, digital reporting of confirmed cases of COVID-19 from doctors to public health center and health checkup for the individual patient isolated at home become much easier compared to the conventional fax or telephone-based systems. The next, please. The biggest challenge in achieving the linkage of claims data with individuals is the identification of individuals based on their health insurance card numbers. Japan has universal health insurance coverage, but because of historical reasons, the incremental approach toward universal coverage, the insurance system is not unified, not single-payer systems. It is not uncommon for individuals to switch between multiple insurance systems and therefore to be assigned another number. It is very difficult to track one individual for a long time. The next, please. And this table shows multiple insurance systems in Japan. Which health insurance he or she should enroll in depend on his or her occupation and age. There are 5 types of insurance systems, such as Kyokai managed health insurance, society managed health insurance, mutual aid association for government employees, national health insurance, and healthcare program for aged 75 and over. Total number of insurance organizations were more than 3,000 as of 2020. So there are many insurance organizations. The next, please. This figure shows the breakdown of health insurance coverage in terms of population in Japan. The colors are linked to the table on the previous slide. Kyokai managed health insurance in purple, society managed health insurance in light blue, mutual aid association for government employee in green, national health insurance in yellow, and program for the aged 75 and over in orange. The next, please. In 2016, Ministry of Internal Affairs started the My Number system, in which a unique 12-digit number was assigned to all Japanese citizens and foreign residents in order to improve convenience for citizens and streamline administrations. And this card system can do official identification for an individual, online application for various administrative procedures, and it is widely used for tax payment, which leads to accurately grasping each individual's incomes. In other words, these systems improve tax equity. This was also the solution to the linkage problem. Minister of Health, Labor and Welfare planned and implemented a policy to link an individual's insurance card number to this 12-digit number so that individuals can continuously access their information even if they change the insurance systems. Also, each individual can use my number card when he or she visit clinics or hospital instead of insurance card. But the problem was its short implementation period, which was set from fall 2021 to fall 2024, just 3 years. The next, please. Due to this short implementation period, just 3 years, the local governments and system design entrepreneurs who actually link them are overloaded. And currently, due to input errors and program bugs, different people's insurance cards and 12-digit numbers are linked, possibly leaking personal information to others. Something is wrong. Although it is this trouble caused by haste, it has become a factor in greatly lowering support for the policy among Japanese people who value privacy, and the progress of the policy may be delayed again. The next, please. These are final remarks. Government plans future linkage with other personal health record or electronic health record, such as medical record. Such linkage will improve efficiency in health services and patient convenience. However, considering the Japanese people place a high value of privacy and data reliability, it should proceed with caution. The risk of simultaneous implementation of health policy for more than 100 million people is imponderable. That is my thought. This concludes my talk. Thank you very much.
Thank you so much. Yeah, I guess having so many insurers makes doing things extremely difficult. 2020 now. But I think some years ago you had over 5,000.
Yes. So there was a progress.
So yeah, so you are doing better. The same thing had happened in Germany. That they went from over 200 to now below 100 insurers. Okay, thank you so much. Let's move to Morten. Yeah, to Morten. Morten, please tell us what Denmark is doing digital health.
Yes, I would like to know if I share my slides now.
Yes.
Yep.
Yes.
Okay.
They were
I can't see
showing and
them.
then they disappeared. So I think you have to share them again.
Okay.
I can see you fine.
We can see them now.
Okay. Thank you. So, thank you for the invitation to this panel discussion. And thank you for very inspiring presentations about the Taiwan and the Japanese healthcare. I will give a possibility to discuss the Taiwan and the Japanese model by comparing to the Danish model of digitalization in healthcare. I'm the CEO of the Danish National eHealth portal called Sundhed. Beneath the portal, we also have the slimmer version on the top of the app. It's called My Health. And I will start out by giving you a short introduction to these platforms, offering free access to personal clinical health data for all citizens in Denmark, all healthcare professionals, and including all healthcare organizations. By the way, Sundhed means health. Then I will explain the Danish healthcare systems and digital health. Here you have a glimpse of our web portal, Sundhed, and our app, My Health. And 30 million visits in the first half of the year means that we have a lot of traffic. Remember, we are only 5.8 million inhabitants in Denmark. Our solutions is for both citizens and health professionals. At Sundhed, you can access a lot of highly qualified health information written by health professionals and the Danish health records, which give access to your electronic health records notes, to your medicine overview, to your vaccinations and lab responses, and your appointments with the healthcare sector, to mention some. By the way, you can also give authorization to a relative or other trusted persons to access your personal data. Or you can access the ones of your elderly parents, and you can access the data of your minor children. So think about your feelings for your family and so on. And so this possibility to give a helping hand to relatives in a digital way really give patient empowerment a new dimension. On the top of Sundhed, we have developed the app called My Health, which is a slimmer and it's a more user-friendly version of the portal for the citizens. And especially lab responses became very important during the COVID-19 pandemic. And it was possible to develop a corona passport pretty fast because we already have all the necessary building blocks. With those two platforms, we had a very good start and a very good starting point when corona spread to Denmark. And actually, the traffic on the portal raised 391% from March 20 to March 21. And we had to expand the number of our servers, our technical servers, from 40 to 106 in a few weeks, so that we could handle 5,000 users per minute instead of 400 on the app. So this is a picture that a good national health IT infrastructure is a strategic, important tool when crises due to pandemics, climate, and war arises. And they do, as we so sadly know. Health professionals have access to exactly the same information and data as the citizens. It's just accessed through different user interfaces. This is the view of Sundhed from the perspective of health professionals. They have medical records, lab responses, description of x-rays, examinations, medication records, vaccinations, and health appointment overview. Due to a system integration, health professionals access Sundhed directly from their own EHR system where they do their everyday work. When you have a patient in treatment, it's just to press a button on your screen and you go directly to this overview. So it's fast, it's easy, and it's very secure. And this slide illustrates different user groups accessing Sundhed and how Sundhed and the Danish health record integrates to national databases and local systems. For the time being, we integrate to more than 170 data sources and look up and display existing data. So data is collected and stored in local, in regional and national databases and EHR systems in the healthcare sector, and they are not stored at Sundhed. We only integrate, display, and reuse data from everyday work out there in the healthcare sector. With Sundhed, health professionals are provided with the possibility to access patient health data from other systems and across sectors and boundaries. In this way, Sundhed is a sort of national EHR solution covering all citizens, all healthcare professionals in every healthcare organization in Denmark. So this is actually a very important step toward patient-centered care and treatment. In general, Denmark is leading in e-government. This UN e-government survey from 2022 ranked Denmark as #1 position, and it was the same position we had in 2018 and 2020. And it's a global ranking among 193 member states. And I'm showing you this because those benchmarking reports pinpointing different drivers for digital development. And I think it's much of it very much reflected in the way we work. So digital strategies is one driver among others, and cooperation across sectors is another driver. So it's much more than just IT developing and new technical solution. And that's why I'll take you shortly through the Danish healthcare system and digital health. First, the Danish healthcare system is universal. It's based on the principles of free and equal access to healthcare for all citizens. And also, we have a long tradition for registration and have been collecting health data from EHR system in everyday work in a national register for more than 14 years. This means we have exactly reliable health data covering the entire population from cradle to grave. And for more than 20 years, digitalization in Denmark has been driven by national strategies for digital government across national, regional, and local government. So these are all key factors when we talk about success factors of Danish healthcare. Besides this, I think it's important to mention that Danes have been used to data collection and registration for decades. And Danes widely trust the public sector and the healthcare sector's handling of the data. And our organization is governed by its own political appointed board with elected politicians and a steering group with representatives from each of its partners' organization. So I think it's worth mentioning that this dimension about democracy and health IT in general is very important when we talk about confidence and access to and sharing clinical data. Because it's a model that ensures that data is handled within a democratic setting and that the data is owned and used by the general public and nobody else. That's important. In the national Danish strategies, you can read that even more health data should be accessible for citizens, relatives, and health professionals at Sundhed. With our board leading the way, we also have our own strategy. It's the one in the middle, the red one in the middle. And our vision is to be a user-centered health universe, creating value and coherence for both health professionals and citizens, and support the empowerment of the citizens. And to be a user-centered universe, we obviously have to know our users. and get them involved when we are developing our solutions. So actually, we do a lot of user data collection to get to know our users. And we have also launched what we call the Sundheds user panel with more than 2,600 citizens and health professionals who take part in an ongoing dialogue when we develop new services or launch new campaigns. And what we're trying is to make simple IT solutions that meet the needs of our users. Because we know that simple IT solutions also is the best way to support digital inclusion. And that's actually a challenge also in Denmark. And this will be, I think, even more important in the years to come. So this was in 8 minutes to give you a very short introduction to our solutions and our approach, and also the possibility to discuss the Taiwan, the Japanese model in this context. So thank you very much, and please, I'm very I look forward to hear what you think about this. Thank you very much.
Thank you so much, Morten. As an American, I can only envy the people of Denmark, of Japan, and of Taiwan. Here, healthcare is pretty chaotic, but that's not what we're discussing today. Jack, the floor is yours. I guess you'll give us the international perspective.
Thank you, May. Thank you very much. And delighted and honored to be on this panel. 3 wonderful presentations. I've learned quite a lot, and I really appreciate that. Now, I do want to raise a few questions from an international perspective, and I wonder if I could go back to Director General Shi. I'm a long-standing admirer of the Taiwanese model, and in fact, you raised the possibility of people visiting. In fact, I did visit Taipei in 2019, and I saw the very impressive gains that you had made with TB care. Reducing incidence and prevalence dramatically over a few years, and in part because of new incentives, and in part because of your IT infrastructure. So that was very useful, and I was there with a number of Indonesian experts. So we learned quite a lot, and Indonesia has taken on some of your good ideas and moved further to now pilot test some of these ideas that we picked up from Taiwan. So I thank you very much for your team to help us so much. I do want to ask Director General Shi a couple of questions, and if you could bring up my slide, that would be very helpful. A couple of questions, not so much to critique your system, but more to say to you, what can low and middle income countries in Asia and Africa, especially in Asia, because I'm working in India, I'm working in Indonesia, I'm also working in the Middle East, as May has mentioned. But what can low and middle income countries learn from some of the issues that you're embracing now? And I just put 3 on the screen. We don't have a lot of time, so I put 3 main ones on the screen. First of all, the move to new incentives in Taiwan is quite impressive. Now you're moving from fee-for-service, you're going to DRGs, you're going to outcome-based payment, you're doing a couple of different pilots on the pay for performance. Very impressive. And, you know, other countries such as India, they're now thinking about moving to DRGs, and they've started the work already. They've done quite a lot on costing. The Indonesians, for example, have said that, yes, they've gotten a good start with their capitation and their DRGs, but at the same time, they really now need to move to much more sophisticated, nuanced ways of paying. And I'm wondering, in the first instance, what are sort of the challenges that you have faced in terms of your IT infrastructure as you change payment models? Okay, so I'd be very interested to hear from you on that. A second issue is more about the telemedicine. We've spent a lot of time on telemedicine in this webinar, And some of the I recently was able to look at some research that's being done by Professor Rachel Liu and Professor Lilin Liang, both at prominent universities in Taiwan. And what they looked at was the use of telemedicine by income levels. And what they found was that the descriptive statistics showed that it was pro-poor. But then when they disaggregated the data and did some multivariate analysis, they found that actually the use of telemedicine may be pro-rich. And you may not, to be fair, you may not have seen this work because it's work in progress and hasn't been published, but nevertheless, I know that your team is already thinking about how you can make telemedicine more accessible to the rural, to the underprivileged. So I don't want you to answer so much to the research and the methodology, but more to say, what steps are you thinking about now in terms of making telemedicine accessible for those who may need it, who may be underprivileged in terms of access to healthcare? And then the third question I have has to do with digital trust. So we heard this across all three presentations. The Danes they have a culture of trust, but at the same time, we see that there are challenges in Japan. And your data information is very rich in Taiwan, and I'm interested to know how you get it out there for researchers, how you get it out there for consumers. But at the same time, you're challenged by some recent court rulings that found that the use of claims data might actually be an infringement on personal privacy. And I've also read through surfing the net that there's been a couple of recent data breaches. So I'm just wondering again, sort of how do you balance these various issues of digital trust, but at the same time, making your data available for research, making it available for consumer review. And there are different models that we see around the world. In the US, you can get social health insurance data, but you have to pay for it. You get it relatively quickly, but you have to pay for it through a private firm. In Indonesia, they have a very good, interesting approach now where they put a 1% sample of claims from their single payer model on the internet so that people can access it. And that's a very interesting way to do things. It may not serve all purposes. If you want to look at a particular district or a particular province, you may not have enough data to do that, but nevertheless, it's a very good start. So I'm just wondering what your thinking is about making data more accessible, especially in light of some of the things that we've encountered, we've seen happen in Taiwan over the past year or so. So let me stop there. Again, DG Shi, thank you so much. Fei Chang Gan Shi, and I look to you just to give a few lessons for low and middle income countries in Asia and elsewhere. Over to you.
DG Shi, I'm not sure we have enough time for you to answer all three questions. So please answer one or two or three if you can manage to fit them all in.
You're just muted, so you just have to unmute yourself. Yep.
Okay. Is work? Okay.
Yes.
Okay. Thank you, Jack, for your so productive comments and the practical questions. Actually, our insurance have adopted a fee for service payment system initially when it was launched in 1995. So in order to enhance the efficiency of the healthcare services, our insurance has gradually implemented the cash basis and the day basis, the payment system, depending on the different healthcare characteristics. Also promoted the quality-based, performance-based payment, aiming to change the providers' behaviors through the payment strategy. We also call the incentive linked to quality and outcome. So in order to the further improve of the efficiency of the healthcare services, we have implemented the DRG, Taiwan DRG payment system since 2010. The implementation and the promotion of the formation that the payment system primarily relied on the infrastructure of the healthcare health insurance information system. So NHIA has established the health insurance information network service system. This is the first step to facilitate the submission of claims, data uploads, and the registration of the care information by providers. In addition to ensuring the information security, the electronic submission and the uploading of the data also contributed to improving the efficiency of the claim acceptance, review, monitoring, management of the insurance program, as well as the calculation of the quality indicators, DRG classification, and the payment parameters. So this so many measures is try to ensure the stable implementation state by state and advancement of the various payment systems. So in summary, health information system is the base for implement the various payment system. So these are our for these our answers for your first questions. The second question is regarding the telemedicine is the pro-reach or not. I think it is maybe right or maybe not. From our view of the point, the telemedicine is very beneficial to shorten the gap. I say the accessibility to enhance the not only to enhance the accessibility in remote area, but also to provide the healthcare services timely. Just as my presentation, the telemedicine was implemented as an emergency response measures in response to the COVID-19 pandemic. So it was gradually open to the different target group based on the stage of the outbreak. So from the feedback and the experience, I think that the infrastructure played the critical role. I mean is the such as the device or the transmission speeds, internet structure, and etc. is very important for success to conduct the telemedicine. So so many challenge such as the internet, the connectivity, video conference, the equipment, as well as the familiarity with the video software in a remote area. So the government or healthcare institution have to provide the instruction of the basic equipment to enhance the accessibility for the those vulnerable population. Let us easy to use that. Taiwan has achieved the national information infrastructure well. We are making it easier to utilize the internet for telemedicine services for providers. On the other hand, we are going to enhance the infrastructure in the remote area to enhance their accessibility for telemedicine. So other countries may need to gradually establish the domestic information infrastructure to conduct the widespread telemedicine services. Your third question is quite critical for data collection, sharing, and the utilization. Regarding the recent ruling by the Constitutional Court, it did not did not impose the limitation on the use of the data for research purpose. Instead, it granted the individuals the right to request the withdrawal from research usage. So our plans is to develop the mechanism to accept the withdrawal request for populations, as well as to exclude the data of applicants from the future research use, ensuring the information autonomy rights of the public. And so, in general, the proper data sharing, the data, particularly our system is the single pair system. So we are very easy to gather all the health data from our populations. And this data is very helpful and powerful. So the proper data sharing helps us to reduce the repeated data collection, administration work, and the cost. However, the people's awareness of information autonomy is increasing emphasized. So and we know the data autonomy is now a public interest. So we have to we have to respect the belief of the citizens. So right now we try to establish the transparency process and the mechanism to accept the withdrawal request from public. I think that maybe by the 2023 we will complete this mechanism, as well as the establish of the governing committee. Yeah, this is my answers. I'm very happy to share with you. Thank you so much.
It's truly excellent, DG Shi, that you managed to answer all three questions fully, beautifully. I think we are, our time is up, but I think I will just borrow 3 minutes for each of the panelists to give us a very quick takeaway or any comments or any recommendations for Taiwan that you would like to make. This is your chance to make policy recommendations to the head, the man who runs Taiwan's NHI. So Yasuki first.
Yeah, digital trust is my concern. So, generally speaking, the people's trust in government, the government is relatively high in Japan, and it worked during the pandemic. The people behaved very modestly according to the government guidelines, and it worked. And but recently the government does proceed the linkage, as I mentioned, too fast. So the trust in the government might be decreased. So I wish the government proceed the things with caution. That's my thought. Thank you very much.
Thank you. You're within 1 minute. Thank you very much. Morton, please.
Thank you very much. First, congratulations with all you have achieved in Taiwan. It's very, very impressive. I mean, also very impressed by the further ideas you have to move on. And I think the way that the relation you have with the users, with the inhabitants of Taiwan, congratulations very much with that, and keep on keeping that strong band. I think it's so important for the further development. I had actually one question, and I don't know if you can answer in few words. Then I will shut down my comments, because I'm so interested in hearing about the self-reporting. I saw that your services was a lot of clinical data, a lot of what we usually see, but then you also have self-reporting. We are very challenged in Denmark using self-reported data, because sometimes the healthcare professionals don't believe what they see and don't react to them, and it's very hard to handle. Those self-reported data has such a big potential. So how do we handle with that? Sorry.
Yes.
Quick answer, 1 minute, please.
Yes, thank you, Mr. Peterson. We have the similar challenge for us, how to facilitate the reporting comprehensively. So I think that we try to establish the mechanism to upload automatically. So it means that we try to reduce the work from the provider side. So I think the system IT support is very important for to encourage the hospital, the clinicians to do that. Yeah.
Thank you.
Thank you. Jack?
You know, May and everyone on the panel, in low and middle income countries, we like to talk about leapfrogging. Leapfrogging, we can just go faster than all of those OECD countries. It took them years to do this, and it took them years to do that. And I've learned a lot today that 3 high-performing systems, the Danish system, the Japanese system, and the Taiwanese system, are making progress, but it's not always a matter of leapfrogging, even for high-performing OECD countries. They have to go step by step. They have challenges. They have to do constant monitoring, adjustments as they go forward. So I think this is another a lesson for low and middle income countries. But I think I've learned a lot today, and I hope many of our colleagues from Asia and Africa have been watching or can watch in the future. Thank you, May.
Thank you. I'd like to thank all of you, DGP, Jack, Morton, Yaski. Thank you so much for making the session a very, very interesting and informative one. Thank you.
Thank you, May. Thank you, Kobayashi Sensei, and Jack, and Mr. Peterson. Thank you so much. We learned a lot from you. Today is the so fruitful dialogue. Thank you so much, and welcome all of you to visit Taiwan in the near future. Thank you so much.